Good evening, everybody. My name is Carolyn Dubé. I'm the Executive Director at Fertility Matters Canada, and I'm thrilled to be with you tonight for another session of our very popular Figuring Out Fertility session, where we speak with fertility experts across really North America to debunk fertility myths, to learn more so that you as the patient can learn and be educated and make more educated decisions about your reproductive health options. I'm thrilled tonight to be with Dr. Bonnie Woolnough from Olive Fertility Center in Vancouver. Olive is a long-standing member of Fertility Matters Canada and supports us. We're a Canadian charity, and they support us financially every year so that we can continue to bring programs like this for free to all Canadian patients. So Dr. Bonnie, thank you so much for being here. I'm really excited to learn more about PCOS. We've got a lot of people that are joining us live. And if you have questions, please, if you're watching on Facebook, put them in the comment section. And if you're on the Zoom platform, you can put them in the chat option and we will get those answered for you tonight.
All right, thank you so much for that lovely introduction, Carolyn. It's my absolute pleasure and privilege to be speaking with you all today. So I want to thank Fertility Matters and Carolyn for inviting me to speak with you all today. And as she's already introduced, our topic today is polycystic ovarian syndrome, or I'm going to be calling it PCOS quite a lot here because it's a bit of a mouthful. So my hope is that I'll be able to help clarify some important concepts about this common condition and then answer any questions you might have to help you really feel educated and empowered when it comes to your fertility decision making. So let's get started here. So I'm just planning on reviewing kind of briefly how we diagnose PCOS, some of the risks that can be associated with that diagnosis, as well as some lifestyle advice that can sometimes be helpful. And then, sort of barring any improvements with that, some fertility treatments that we do have as options that might be the right choice for you. So PCOS is a common condition, especially among people that I see in my office day to day. So just a little bit of an overview here. So up to 8% of all reproductive age women do have a diagnosis of PCOS. It's one of the most common reasons for irregular periods. And even about a third of women who get no periods at all do have a diagnosis of PCOS. It can be associated with symptoms that are related to higher male hormone levels that can lead to symptoms like acne and hair growth, where you would sort of expect it to be in a male pattern, so on the lip or the chin or even the abdomen. And it can also be associated with other medical conditions like diabetes, high blood pressure, or sleep apnea, which we'll talk a little bit more about as well. So our current understanding of PCOS is that there really are multiple factors leading to the symptoms that we see. So it seems to really stem from within the body there being a resistance to insulin, which is sort of the hormone that we think about as being associated with diabetes. And so when there's a resistance, it results in an increase in the insulin levels within the body. And that can lead to multiple different things throughout the body, including within the brain. A hormone that's produced called LH, or luteinizing hormone, is released typically at higher levels than usually would be. And then that can result in its effects on the ovaries, resulting in higher male hormone production within those ovaries. And this can sort of lead to a feedback loop that just perpetuates that cycle and kind of can make the whole hormonal imbalance worse over time. So it's important to remember that PCOS doesn't look like one single thing. It's a constellation of symptoms, and it can be a little bit different for everyone. But there are these overarching features that can be seen and are what we use to diagnose the condition. So because PCOS can be variable in its presentation, it's been controversial over the years how to define and diagnose it. So you can see here there are sort of these three different overarching ways that have been developed over time. But the most common criteria are what's called the Rotterdam criteria, which were developed back in 2004. And really, they included three different criteria, and you have to have two of those three things to qualify, I guess, for a diagnosis of PCOS. So that's this category in the middle here. And so the three things that are required to have two of them would be symptoms of those higher male hormones like the acne and the hair growth, or even just signs of that with the hormone levels in the blood. Number two would be the irregular period kind of picture. So either the cycles are not predictable or they go away altogether. And third is this typical way that the ovaries look on ultrasound with lots of little, we call them cysts, but they're truly follicles. So little fluid-filled sacs that contain the eggs. And we start to see more of them in the setting of PCOS. So in order to confirm the diagnosis of PCOS, other conditions that can act somewhat like it need to be ruled out as well. And we do that primarily through history taking, physical exam, and lab tests to help us show the presence or absence of these conditions. And so these are just, the main ones that we really want to make sure are not just acting like PCOS, because the treatment is often different for these conditions, but they can present in similar ways, either because they also lead to high male hormone levels or other things that can cause irregular periods. So the first three here are those ones that lead to higher male hormone levels and the symptoms associated with that. Congenital adrenal hyperplasia is this thing that you can be born with that leads to that whole picture actually of irregular periods, increased hair growth and things, but it can be slightly different. Cushing syndrome is a condition again related to the adrenal glands, but is often seen with things like high blood pressure and other very characteristic features that we see on someone's body on a physical exam. And of course, tumors can also release these hormone levels. And we want to, of course, make sure that people are safe and not having these kinds of tumors that need other treatment and management. The other two conditions below are other sort of hormonal imbalances. Prolactin is another hormone that's released from the brain. And the thyroid, if it is either too high or too low functioning, can also lead to irregular periods and lack of ovulation or release of those eggs. So all of those things need to be ruled out. And some of the blood work that we would often order to sort of assess what truly is going on is just seen on this slide here. Can also be useful to suggest the higher male hormone levels that we do just see in PCOS and confirm that diagnosis. So to aid in that diagnosis, an ultrasound can also be done. So this is just a characteristic appearance of an ovary on ultrasound with PCOS. So these little dark circles are all the follicles, like I said, that contain the eggs. And when there's lots of them, so 12 or more in each ovary, then that is characteristic and diagnostic of the look of PCO. So it's important to remember that this ultrasound finding on its own does not give a diagnosis of PCOS. It needs to be in conjunction with at least one of those other features. Sometimes if we don't clearly see the number of follicles, the overall size of the ovaries can be suggestive as well. So I mentioned earlier that there are some other medical risks associated with having been diagnosed with PCOS. One of those that's very important to know about is an increased risk of precancerous or even cancerous changes to the lining of the uterus called the endometrium. And this is related to the hormonal changes when we don't ovulate, such as in PCOS. And so if the lining of the uterus is not shed regularly with a regular period, it can just sort of build up and up. And that building up doesn't let it just sort of be kind of flushed out. And so if you don't have kind of the general consensus is at least about a period a season, it's not enough to really help protect the lining of the uterus. And so the recommendation would be to have medication to either bring on a period or to keep the lining thin in the first place, especially outside of the setting of actively trying to conceive. Some other conditions that are of increased risk in PCOS include diabetes, high blood pressure, and high cholesterol, as well as depression and sleep apnea. And so these are conditions that, it's good to always have, say, a family doctor, somebody that can monitor you for these conditions over time. Because while you might not have these conditions at the time of a diagnosis, it can develop with time. And so there are several different approaches that can be taken to help women with PCOS to conceive. And I'm going to kind of focus in now on the fertility side of things at this point. So I'm going to go through each of these approaches one by one. So for women who may carry extra weight, lifestyle changes, if they're necessary to maintain a weight as close to ideal as possible, will help to improve things like pregnancy rates, decrease miscarriages, as well as to improve the chance of success of fertility treatments if they become necessary. And so certainly a healthy diet, and kind of from an overall fertility perspective, the Mediterranean diet has really been shown to be kind of the most fertility friendly. And exercise combined to maintain a healthy weight are of course a mainstay there. There are certain indications where bariatric surgery or weight loss surgery might be indicated. And if you think this might apply to you, your doctor can help guide you in that. And it's been even shown that weight loss of as little as 5% of your body weight, if you're overweight to start, can make a difference. So let's say you've been trying with all of these lifestyle factors, and sometimes it can be a bit resistant and it can be tricky to say lose that weight, or even if you lose some weight, maybe you're still not having regular periods and ovulating regularly. So then we have fertility medication options. And the first line option that we would typically recommend is a medication called Letrozole, and that's a pill that we use to help women ovulate. It's been shown, compared with another pill that's been used for many years called Clomid, Letrozole has been shown to improve live birth rates over Clomid. So it's typically recommended as first line, specifically for women with PCOS. Now, there may be reasons why Clomid might be chosen. For example, if you had bad side effects on Letrozole, but certainly both of these remain an option. The main risk associated with this treatment is the chance of twins, which on average is about 5 to 10% chance when you conceive with this medication.
Dr. Bonnie, so I just want to jump in there for 1 second. So if someone was interested, if they know they've got a PCOS diagnosis, what would be their first step to access care? Would they go directly to their family doctor? Would they go to a gynecologist or their OB specialist, or would they go right to a fertility clinic, or what does that look like?
Yeah, so there certainly are different options, and I think that those options look a little bit different across the country. Absolutely, your first kind of best connection with what's available to you in your area is meeting with your family doctor if you have one. And, you know, if that family doctor themselves is not comfortable or familiar with confirming the diagnosis and prescribing this medication, then they should know who they're able to refer to in your area, whether it's a general gynecologist or a fertility specialist. But it would be typically one of those who would be most comfortable and familiar with diagnosing and treating PCOS. Yeah,
Great.
Good question.
Thank you.
So yeah, I'll move along here, and I'm just going to show you, this is a little bit of a visual sense of what a treatment cycle, we talk about treatment always in cycles because it's always around the cycle of a period. And so both pills are given typically in a 5-day course from the 3rd day of the period through to the 7th day. And then when the follicle, or this little fluid-filled sac that contains the egg, is at a point that it would be mature, it either would release naturally because of the medication, or with some assistance with a second medication by injection. And then once that egg is released, either intercourse at home or insemination, if it's necessary in a fertility clinic, would be able to allow for possible fertilization of the release of that egg. And really, it's the release of the egg that we're helping to happen with that pill, because that's what we're seeing not happen predictably in PCOS.
And with someone with that ovulation, what are the statistics around the number of eggs that are released in any given cycle? Is there any data on that? And is that why twins become more of a risk factor? I know lots of people don't want to talk about twins being a risk factor, but there's lots of challenges with a twin pregnancy, and so I'm just curious about that.
Yeah, do you mean, Carolyn, the chance of multiple follicles developing with these medications, right? Yeah,
Yes.
so that's where that rate of about 5 to 10% chance of twins comes from, is that possibility of multiple follicles developing. So the dose of the medication is important to really try to identify the correct dose to have you release one, maybe two follicles, and that's really where the multiples rates comes. Um, the goal in this kind of treatment is not to release more eggs than that. If we have more eggs being released because of a stronger response to the medication, that's where we start to see higher rates of twins. And I'm going to talk about that sort of with the next sort of
Awesome. Okay.
step of medication and sort of the difference in twin rates associated with that.
Okay, great.
Mm-hmm.
Thank you.
You bet. So this is not kind of the next step that I'm talking about, but this is sort of just a good little aside. So there's another medication that I wouldn't classify it necessarily as a fertility medication because it has not been shown to increase the chance of a live birth, which of course is always our ultimate goal. But metformin is a medication that's been used for decades in the treatment primarily of diabetes or prediabetes. It's been shown sort of inconsistently in studies to maybe be able to help with weight loss. So sometimes that can be helpful for people who struggle with weight loss. And certainly it has been shown to increase the chance of ovulation and having regular cycles. And maybe it can reduce the miscarriage rate. But one of its clearest benefits really appears to be in the prevention of metabolic health complications like diabetes. And it's not recommended on its own as a fertility treatment because of the presence of these other medications that are very clearly more effective. But it's one of those things that if you are someone who's already in a position of being at risk for diabetes and all of these things, it's an option to talk to your doctor about. One of the main potential risks of it is the side effects. It can be hard on the stomach, and so that can be a little bit of a limiting factor, but certainly an option that's out there.
What are some of the side effects? We just had a question from someone come in that asked about the side effects of metformin.
Yeah, so its most common side effect is stomach upset, so nausea, vomiting, diarrhea. It's most commonly dose related. So if you start on too high of a dose, it can be a bit of an all at once impact, but it can often be kind of mitigated by starting at a very low dose and gradually working up to the kind of the intended goal target dose. And but really the gastrointestinal stuff is the biggest issue. There is a small risk of something called acidosis. Usually that's in the setting of, if you already have kidney or liver dysfunction. So that's why it's important to talk to your doctor if it's right for you. But most commonly it's those stomach side effects. And they're usually self-limiting. So if you can kind of press on through them, usually they go away with time.
Great, thank you for that.
Yeah. So then sort of moving on to the next potential option after the fertility pills to help with ovulation. If, those oral medications are not sufficient to help result in ovulation, this is another option to help, and that's actually injectable medications. So you'll hear them called Gonadotropins or FSH, lots of different brand names that are thrown around out there. But basically, it's an injection that you would learn to give yourself every day during that early part of the cycle. And so you'll see, so the pregnancy rates are often seen a little bit higher than the pills, but it comes along with an increase in that twin risk. So you'll see it's kind of about double. And that's because of the possibility of developing more follicles that mature than we do see typically with the pills. So just because I know there were some questions about side effects, I'll touch on the side effects of these as well. So of course, because it's an injection, you can have some sensitivity at the site of those injections, as well because it's hormonal, it's those hormonal side effects that you might feel, things like mood changes, abdominal bloating or nausea, breast tenderness, headaches, these kinds of things. Typically at the doses that we use for this kind of treatment, it's a lower dose. And so risks like ovarian hyperstimulation, which I'll talk a little bit about later, are not as prevalent, but certainly still possible even at the lower doses we use for developing the follicles at a lower number. So again, this is just that kind of visual of that, of multiple days of injections, and the number of days does depend woman to woman on how long her ovaries take to respond. Oftentimes we will use a final injection of that different medication. It's actually usually the pregnancy hormone to trigger release of those eggs if need be, and then either typically it will be combined with insemination once we're using those injectable medications. So for some folks, either if you know, those treatment options are not successful, or they've been trying for a while, or time is a little bit more of a pressing factor. For example, if the woman is older, the couple might choose to proceed either directly or after other tries to something like IVF, in vitro fertilization. It's one of those ones that most people have kind of heard about in popular media and the movies, but just to kind of recap a little bit about what it involves. So it's, again, involving injectable medications to stimulate the ovaries, only instead of a goal of releasing, say, 1 or 2 eggs, where we're just trying to get a woman with PCOS to ovulate, we're trying to get sort of a whole bunch of eggs. And then those eggs are then removed from the ovaries through a vaginal ultrasound-guided procedure with the needle that drains that. The eggs are then combined with the sperm in the lab to make embryos, which develop in the lab, and then ultimately an embryo is placed into the uterus. So it's a lot more involved of a treatment, a lot more costly, certainly, on average. And again, this is going to depend on the clinic and sort of the typical expenses involved, but typically about $10,000 or so per treatment try, plus the cost of medications, which is usually several thousand as well. So women with PCOS typically have good responses to this kind of treatment, and similar pregnancy rates as those women who don't have PCOS, which is great. One of the things when we have lots of follicles in the ovaries is that there is a higher chance of a very high response with lots of follicles developing and lots of eggs growing. And that's where we start to see a higher risk, particularly in women with PCOS, of ovarian hyperstimulation syndrome, which is basically a condition where the ovaries are so stimulated that it leads to hormonal changes that leads to the blood vessels actually becoming a bit leaky. It means that fluid can accumulate in the abdomen, or even in more severe cases around the lungs or the heart. Can sometimes need treatment like having that fluid drained out of the abdomen. But that's much more rare, but certainly is something that is possible with that setting of OHSS.
We do have a question that came in,
Yeah.
and you may touch on this, but is there any testing or ultrasound? Do you do an ultrasound to confirm that the medication worked in a cycle and that the egg will be released? Or is that possible?
Is that a question about IVF or the other treatments not IVF? Do we know?
It's not specific, so
Okay.
maybe
So I can touch a little bit on both of them, perhaps.
Mm-hmm.
So yes, during treatment, specifically for sure with IVF or with the injectable medications, we would monitor during a treatment cycle with ultrasound, plus or minus some blood work. Everybody's a little bit different how they do that monitoring, to see, yes, how many follicles are being grown, and making sure that you're responding appropriately to the medication. There may be some room for adjusting medications partway through the cycle, again, depending on the exact clinical situation. And then we watch to see when those follicles reach a size that we expect the eggs inside to be mature, or at least as many of them as possible. And when we see that size of the follicles, that's when we would plan to trigger for release of the eggs and either an insemination or the IVF process, depending which treatment is happening. I hope that answers that question.
Yeah, that was great. Thank you.
Okay. So then One other option that is available, and it can be an option, for example, for women who might not release an egg through ovulation despite the pills or the injections we talked about, or if for whatever reason those medications are not an option for them. So this surgery, and it's called ovarian drilling. It sounds a little bit intense, I think, but basically it's a process where through a laparoscopic surgery or a camera, usually through the belly button and one or two incisions elsewhere on the abdomen, some instruments are introduced. And so this picture here is of an ovary. This white spot is the ovary. And this is a little electrode that causes the little burns on the surface of the ovary. And that it impacts the cells on that surface of the ovary that produce the male producing hormones. And so when we damage a little bit of that tissue, it can help to kind of restore the appropriate hormonal balance, at least for a time being. So for some women who have this procedure done, it's done with a goal of, hopefully allowing that woman to ovulate either without the use of medications or to be able to respond better to those medications, even if they don't start to necessarily ovulate naturally. Yeah,
What's the time? I see the wait time. Does that mean on your slide, does that mean wait time to get into treatment, or the wait time between the procedure and when you would move on to treatment or could expect to see changes?
So that's the wait time for the surgery itself. And again, so this is specifically in Vancouver in BC for our location, which actually it might not even be super up to date because of course everything is finding wait lists a little bit longer with the impacts of COVID-19. So it definitely will depend on your local friendly gynecologist and what their wait lists are like. Yeah.
And then once that procedure's completed, how long, or what's the wait time after when you can expect to see some changes?
So typically it should be seen pretty well right away. So if you're going to start ovulating, we should expect, maybe within a month or so, just to kind of recover from the surgery, but we should expect to start seeing an impact if we're going to right away. Mm-hmm.
Awesome. Great. Thanks.
Yeah. So yeah, certainly surgery, of course, comes with its own set of risks, and that can include things like damage on the reserve of those ovaries, if that's a concern. So it needs to be determined on an individualized basis with your physician if it's the right choice for you as well, just like any of these options that I've been discussing. So just to summarize, PCOS certainly is a complex disorder with many different possible impacts on a woman's health and fertility. It is a common cause of infertility, but we do certainly have many highly effective treatments to help women and their partners to conceive. And so I'm not sure, Carolyn, if you've got a bunch more questions in the chat, but I'd be happy to answer any questions further that we might have.
Great. Okay, so I do have a question. This one says, I'm wondering if doctors recommend those who are not overweight to focus on weight and exercise as a means of increasing fertility.
So that's a good question. So certainly we want to maintain a healthy weight. So if you are already at a healthy weight, I would not typically expect weight loss to be, of further additive effect. If you're maintaining a healthy diet and lifestyle, well-balanced diet and regular exercise, of course, I'm always going to recommend both of those things, regardless of what your weight is, to have a general healthy body. But with a goal of weight loss, not so much. I want you to have all of the appropriate nutrients that you need for a potential future pregnancy, all of that, though, absolutely. And even just maintenance of that weight, right? We know that as we get older, sometimes it can be tricky to keep our weight at what it might used to have been easier to.
Definitely. And for people with PCOS, is there so the Mediterranean diet is a recommendation. So if someone's got questions about that, should they go to a nutritionist? What would you recommend as sort of the next step to get advice on a diet? And and maybe one that's more effective for someone with PCOS?
Yeah, so certainly if you're looking for very specific recommendations, yeah, a nutritionist or a dietitian would be a great start. You know, again, a family doctor would be a really excellent resource as well. Now, truly, there's not been a lot of great research done in what specific kind of diet might be the best for someone with PCOS. A colleague of mine has published on this recently, looking at, you know, the lower carbohydrate kind of diet. And some women certainly do find that to be an easier version of weight loss for them. But I think that it's important just to remember that there's no one size fits all, and that the kind of diet that really is working for you and that you can maintain over the long term as not so much a diet as a lifestyle change that you can continue on into the future is going to be the best one. Right?
Great. And if people have some questions on that, we've recently done a Figuring Out Fertility. We did one last week. If you go to the Facebook page of Fertility Matters Canada or our YouTube channel, you'll be able to kind of search for some other PCOS talks there. So there, I believe there might be some additional information there that would support what Dr. Bonnie is telling you. So might be an option. Okay, we've got lots of questions coming in now. This is my favorite part. I love having patients have direct access to fertility experts. What BMI is acceptable?
So acceptable is an interesting question. So if we look at sort of by a number, of course, I'm saying all this recognizing that BMI is not a perfect measurement of health or weight. You know, we know that it's not reflective of somebody who has a higher, you know, muscle mass, for example. But kind of in the studies that say this is what a normal BMI is, it's 18 to 25, which is calculated based on your height divided by your weight. So, sorry, your weight divided by your height. So it's kilograms divided by meters squared. So if you wish to calculate it, there's lots of online little calculations you can do. But so that would be sort of what's considered ideal. Acceptable is, I think, a little bit of a different question, because sometimes that can be variable and it can depend on different things, like what kind of treatment are you hoping to do? And there can sometimes be limitations, not necessarily because just the weight is high, but because there are restrictions on a lot of our fertility clinics. Oh, did something just happen?
That was me. I stopped sharing so that now that we're live with the screen, now we won't flick back and forth between our videos. I apologize.
Okay, no worries. I just wanted to make sure everyone could still hear okay. So yeah, as far as, you know, sometimes there are restrictions on a certain BMI cutoff beyond which we're not allowed to, for example, give sedation medication for an IVF treatment, for example, when we actually remove the eggs. So some clinics will have specific cutoffs beyond which we cannot do certain treatments because of those restrictions. But that's different than sort of what is ideal from a kind of best health leading into a pregnancy perspective.
Absolutely. Great, thank you. Does sugar impact ovulation and PCOS? Sorry, sugar intake.
So it all ties in, I think, to the insulin resistance that I was talking about. And so when we have an increased resistance to insulin and an elevated production of insulin within the body, certainly intake of sugar will further increase the insulin production in sort of these spikes with the sugar intake. So it certainly, I would say, excess sugar intake, it would be considered to be fighting against what we would try to do to optimize the hormonal changes in PCOS. Yeah.
Okay, great. And that's why the recommendation of the Mediterranean diet can be more helpful. Great.
Exactly.
Can a pap test show any indication or indicators of PCOS?
No. So a pap test is a screening tool for sorry, my screen just turned on the screensaver. Yes, so a pap test is a screening tool for precancerous changes of the cervix, which is not related to PCOS. It's related to a virus that you contract and affects the cervix. So no, a pap would not be expected to tell you something about PCOS.
Okay. Did these treatments work for those who are in a more advanced age in the 39 to 40-year-old range?
Good question. So again, it's going to be very individually determined based on, what the reserve of your ovaries is looking like. But generally, for women who do have a diagnosis of PCOS, these treatments will still be effective at helping a woman to ovulate, so long as she still has eggs, in that setting of a higher age. We still expect to see the impacts of age on the eggs that are being released, meaning we expect a higher proportion of those eggs to be genetically or chromosomally abnormal. So pregnancy rates will still be expected to be lower based on the higher a woman's age is. But yeah, that we would still expect that the treatments that I've outlined would have the same impact so long as you have the eggs to work with.
Great, thank you for that. Do you have any advice on how to track ovulation with PCOS with irregular cycles? I find the LH strips are always high. That's a good question. We do hear that one a lot in our support groups that are online.
And it can be very difficult, especially if your cycles are really irregular, because you don't know when to start testing or when to stop testing, right? And especially if your body and your hormones are such that, like I mentioned earlier on in the talk, the LH hormone is commonly higher than typical. It's not sort of a diagnostic feature, but we often see it at a higher than typical level. And so if your just baseline LH hormone level is already kind of high and it's above the threshold of that urine ovulation predictor kit, that's what it's detecting, is the LH level typically. And so if it's already so high that the kit's saying, yep, you're ovulating, it's not going to be helpful to be able to distinguish when it actually goes up even further with an ovulation, however irregularly that might happen. So if you're the kind of person that just runs with a high LH, those kits are never going to work for you, unfortunately. Or I shouldn't say never, but it's not going to be predictable.
It'll be a challenge.
Yeah.
Yeah.
And that's the kind of setting where, your doctor might recommend things like blood testing to identify when that surge is happening. But if you're trying to conceive naturally without any kind of medication and you're just trying to watch for when that ovulation happens, it can become very tricky, especially if the cycles are 2-3 months apart. Maybe you never ovulate in that time, or maybe you ovulate very late in that time because it's just so irregular. And so typically, if that's the case, I don't actually recommend using those kits because I don't find them to be terribly helpful. If you're trying to conceive together at home with a partner, then I would really just recommend regular intercourse. Kind of always to be able to kind of optimize the chance of there being sperm where it needs to be at the time that an egg may happen to be released. And when I say always, I don't mean every day.
No.
I know that could expect to be to get a bit exhausting after a longer time of trying. But I really would recommend that if you have super irregular cycles and you can't really figure out when or that you are ovulating, that's when you should be seeing a doctor to be able to try to help ovulate regularly. Because if you're not releasing an egg, then attempts at conception are really just not going to be expected to be terribly beneficial.
Great, thank you for that. I have been diagnosed as a lean PCOS, as I don't fit the criteria for PCOS. I went for a pelvic and vaginal ultrasound and was found to have cysts in my ovaries. What would you recommend for helping to regulate or help my menstrual cycle return?
So there's a lot of specific questions in that question. So again, and I'm not sure, there's the mention of diagnosed of cysts in the ovaries. So like I said, PCOS is not truly cysts in the ovaries. It's these little follicles that we see lots of little teeny tiny ones. So if you've been told you have actual cysts, that's a different thing. Again, depending on kind of what criteria your physician is using, you don't need to carry extra weight to have a diagnosis of PCOS. So this idea of lean PCOS is still a diagnosis of PCOS, either because of irregular periods. If the cysts that you're talking about are actually just lots of follicles, diagnostic of PCOS, sure, that meets the criteria. But if you don't have the findings that otherwise meet the criteria, then certainly treatment would be perhaps different. So I don't think I have enough information to really be able to make a specific recommendation, but that does sound like something that needs a further conversation maybe with your physician.
Great. Thank you. And I know sometimes for our viewers, sometimes it's very difficult for the experts that we speak with until they see a patient in person and know a bit more about your very specific medical history. It's really hard to sometimes comment. So take the information that you hear tonight as not as a medical diagnosis, but as information to help you further your investigations.
Right. And to ask questions and, to be able to just sort of further inform yourself together with your own doctor as well.
Yes, exactly. If you are ovulating, is it best to have intercourse every day or every other day? I think we kind of touched on this, but it's probably good to get specific.
Yeah, so the studies would tell us that there may be a little incremental increase in pregnancy rates with intercourse every day compared to every other day. But it's slight enough that, again, recognizing that sometimes, especially if a couple's been trying to conceive for a longer period of time, it can become unsustainable to have intercourse that frequently, with the busyness of our lives and just having the energy, let's face it, to be trying as often as that. Every other day would be considered to be more or less the same. And so that would be the recommendation for frequency of intercourse to maximize the chance of pregnancy.
Great, thank you. Is cervical mucus always tied to ovulation?
Cervical mucus is difficult to interpret. And so while some women may notice, and especially if they ovulate very regularly, they may notice a very consistent change throughout the cycle. But I would say because it is difficult to interpret, it's not something that I usually recommend sort of trying to track, especially in PCOS, where we're expecting cycles to be irregular and difficult to predict otherwise.
Great, thank you for that. I have PCOS and had IVF done last month, and the pregnancy became ectopic. What is the risk if this will happen again with PCOS, and how can I prevent it in the future IVF cycles?
Okay, so truly PCOS is not a risk factor for ectopic pregnancy. I'm sorry that you went through that. That's not
Me
fun.
too. It's hard.
Yeah. So really, and I don't know, the other potential risk factors that might be there, but from knowing that you've had an ectopic pregnancy before, that really is your biggest risk factor moving forward, knowing that you've had one before. And so typically in the setting of knowing that you've had one, there's not really something that can be done to prevent it, but early monitoring to identify the location of a pregnancy is going to be sort of the best way to identify before it can cause you harm should you have another pregnancy that winds up in a place it's not supposed to be.
Great, thank you for that. We've got a couple of minutes left, so we can get to just a few more questions. I did an egg retrieval 2 weeks ago and still feel tender in my pelvic area. Is it normal to take more than 2 weeks to heal from the procedure? I'm going to double check. It's not clear if this person has PCOS or not, but they didn't indicate that.
It's a general question about recovery. So the ovaries are expected to stay large for a number of weeks after treatment. So you may still feel tender If it's more than tenderness, though, it might be worth touching base with your fertility clinic, because there are always the possibility of things like infection or other things that could be leading to worsened pain. And so we don't want to miss any of those nasty things. So tenderness, yes. More than tenderness, should check with your doc.
Great. Then is it normal to feel a little bit of pain during intercourse 2 weeks after retrieval?
Yeah.
That's a hard one. I know, it's so.
And, certainly with having had, a stimulation to the ovaries are bigger than they're used to being. They're still bigger 2 weeks out. And so they sit right at the top of the vagina. So if there is movement there, you can imagine that, yeah, that could lead to increased tenderness. The other potential concern is, really kind of shortly after a stimulation, is that if there is, still a follicle that has refilled with blood, as we expect them to do after the procedure, if there's too much pressure, well, maybe something can actually injure that. Okay. Or if there's too much movement and jostling, an enlarged ovary can twist on itself, leading to increased risk of, cut off of the blood supply. So that's why usually your fertility doctor will tell you, no vigorous exercise, no intercourse for a period of time. So yeah, I would say it would be expected to have some discomfort, but maybe if you're having that discomfort, just back off for a while.
That's great. Thank you. That's really good advice. I think we've answered the majority of our questions. So I guess in closing, is there anything you'd like to kind of close the session with?
I think really just to say that in general, PCOS is a really treatable condition. There's lots of people out there across the country who are happy to help with finding the best treatment for you. I think actually right now, in the setting of so much telehealth, with all of the visits that so many doctors are doing being somewhat like this, either by a phone call or a video conference, even if you live more rurally, it can actually help to open up some accessibility to the specialists. So I think that right now is actually really a very silver lining kind of time for meeting with a specialist if you need to, because we do certainly have lots of options available.
Agreed. I think that that's a great piece of advice. It's a great time to connect with a fertility specialist if you have questions. Always advocate for your reproductive health. We encourage patients, if you're looking for information, to follow Fertility Matters Canada on Facebook and Instagram. Check us out on our webpage. You'll be able to connect with fertility experts across this country. If you connect with us and have questions, please don't hesitate to reach out if you're looking for support. We have free online support groups, and they're provincially based. So please reach out to us if you're looking to connect with a network of people who are also struggling with fertility issues. And Fertility Matters Canada, as many of you know, is a Canadian charity, and we rely on charitable dollars. So in this time of giving, this season of giving, if you're able to donate, make Fertility Matters Canada your fertility choice. All of our donations go back to the education and information and resources that we provide to patients across the country. So thank you for your time tonight, Dr. Bonnie. We appreciate everything that you've been educating us on. Thank you to all of Fertility Centre in Vancouver for your continued support of Fertility Matters Canada. For everybody who tuned in live and asked questions, thank you for being here. And if you're watching on the replay, we hope that you enjoyed this session and gained some information. So if you need to talk to Dr. Bonnie, please reach out to Olive Fertility Centre, and they'll connect you to her. And please join us again for another session of Figuring Out Fertility. Thanks everybody for your time.
Thanks everyone. Have a good night.
Bye.
Bye.